Hi, I'm Dr. Chaudhry. I'm a site director at one of our programs for OBHG in California. And I wanted to share a story about a patient that I took care of. So, this patient is a 42-year-old female. She had had four vaginal deliveries, and then her last pregnancy, she actually had a C section. So, she presented to our triage area at the hospital, and she was 38 weeks pregnant. She came in with some mild complaints of a little bit of a headache and also some cramping. We evaluated her and realized that her blood pressure was elevated. She was worked up and was actually diagnosed with a diagnosis of preeclampsia. Preeclampsia is a condition in pregnancy which can cause high blood pressures, but it can also cause other issues. It can affect the baby's growth, and mom can get sick. And one of the things we get concerned about as a serious complication is even seizures for the mom. Anyway, luckily, the patient's preeclampsia wasn't so severe, but she did need to be delivered. We discussed how she would be delivered. And one of the nice things at the hospital is that because we're there 24/7, we're able to provide the option for the patient to do something called a VBAC. Essentially, she can try to have a vaginal delivery even though she's had a C-section in the past. And C-section is a risk for higher complications, the most serious thing being that the scar from the previous C-section could actually open, and that's quite dangerous to mom and baby. Anyway, the patient was counseled about her options, and it is recommended that if she's a good candidate for it, she should try to have a vaginal delivery. Again, we had the resources at the hospital, so we were able to offer that, and she felt good about it. In fact, that was her plan all along. Patient's labor course was fairly unremarkable. Her blood pressures were controlled. She was dilating. She was doing well. Baby looked great. She became fully dilated and actually fairly unremarkably had a vaginal birth. She was really excited about this. I will mention as an aside, there was actually another family because she was carrying a surrogate pregnancy. So actually multiple families were overjoyed with the experience. After the delivery, a patient started to have a fair amount of bleeding, considerably more than normal, and her placenta was not delivering in a timely fashion. Usually that should happen within the first 15 or so minutes. We got to that point and the placenta hadn't delivered. Patient was fairly uncomfortable when I tried to examine her, so we decided the safest thing was to go to the operating room, really get her some good anesthesia, and then evaluate the situation with the placenta. In the OR, I also requested an ultrasound technologist to come in so we could concurrently evaluate what was happening inside the uterus as far as the placenta, but also if I needed to do a procedure like a DNC to help get the tissue out, the ultrasound would help see better. And that's basically what we did. We did the procedure. I tried to remove the placenta, but it became pretty apparent that the placenta was not going to be released. On ultrasound, you could almost see where the placenta, or at least part of it, was stuck to where the previous C-section had been done. So that scar became a point for attachment of the placenta, and the placenta wouldn't come off. So that's an issue because we need to remove the placenta, otherwise the patient can bleed and get infected and really get quite sick. At the same time, it's not coming vaginally, and this diagnosis is called a placenta accreta. That requires a hysterectomy. So that's what we had to do. By this point, the patient had lost quite a bit of blood, enough that we instituted something called the massive transfusion protocol. Essentially, the blood bank knows that when this is called on the OB unit, we need to mobilize blood products. So that includes the normal blood that we see, the red blood cells, but also other things like platelets that help to prevent further bleeding. The patient had to undergo a hysterectomy. It's a pretty complicated surgery relative to someone who's not pregnant. You can imagine all this blood going to the uterus to initially support the pregnancy and the baby, to give the baby the oxygen and nutrients it needs. Well, now that same blood could potentially bleed and become a real problem for mom. Fortunately, we had a very successful outcome. The hysterectomy went well. The team was really well organized. The resources were available. The patient did have to go to the ICU initially after her surgery for about a day and a half, but really she had a pretty unremarkable recovery after that and did very well. So this was a wonderful example of the care that was provided by the OBHG team. As I was reflecting on this case, several sort of important points came to mind that I'd like to share with you. And they have to do with the difference between having someone like a hospitalist 24/7 available versus a situation where you might not have a physician like that in the hospital. So, for instance, number one, we had the opportunity to actually offer the patient a trial of labor. A lot of patients have had a C-section and they would like to try to have a vaginal delivery, but you really need to have an OB on the unit at all times pretty much. So with a hospitalist, that's actually an option for that patient. Some places the patient wants a C-section, there is not a laborist or a hospitalist on the OB unit, and therefore sometimes they can't offer that, which increases sort of potential complications for the patient. So that's an important piece that a hospitalist can provide. Additionally, some of the things that we do that maybe you don't see face-to-face when a patient is there is that we do something called simulation. That's really a lot of training with the OB doctors, the nurses, anesthesia doctors, everybody, so that if a complication such as this arises, we're ready to take care of it. And in our hospital, the OB hospitalist team has been a big part of those drills, simulations, and training. And I think that's a reason why this patient had a good outcome. She got to the point where she needed a lot of blood and she needed a surgical procedure. And in order to do that, we were streamlined, we had been trained, and our team was on top of things. And that's why we were able to give timely and efficient and effective care to the patient. The other thing that the hospitalist program did is we taught and essentially worked with the hospital to make sure that there was something called a massive transfusion protocol, which really means when the mom, is bleeding so much that there's a danger of essentially loss of life. We've worked with the hospital to make sure that such blood products are available. Like I was referring to the red blood cells and things like platelets. Those are critical in terms of the life-saving maneuvers for the patient. All of that to say that, in this situation, the doctor whose patient this was, the private doctor in the community, he works closely with the OB hospitalist team, but he was not able to be present for this delivery. He had actually signed out the patient to us and asked that the hospitalist team take care of the patient because he was not going to be available. So you can't imagine what it would be like if someone like a hospitalist was not present and how that would have been handled. Potential delays in care and who would have taken care of this critical situation. For that reason, and for all that the laborist can provide, I'm grateful that we have this service at our hospital, and I think it serves the community and our patients and supports our colleagues in their offices and the doctors there as well.